All right. Good morning, everyone, and Happy New Year. This is the first Hamilton Health Sciences medical grand round for the year. I will start with the land acknowledgement. We are privileged at Hamilton Health Sciences to be providing care on lands that Indigenous people have called home for thousands of years. I want to acknowledge that I'm situated upon traditional territories of the Haudenosaunee and Mississaugas. This land is covered by the dish with one spoon agreement between the Haudenosaunee and Anishinaabe, and all of us on this land to share and care for the resources around the Great Lake. Please take a moment and reflect and give thanks to those who have been before us on this land, understanding that we are in a virtual grand rounds today, and our speaker is actually from across the country, from Alberta, so we all could be on different lands, so we'll take a moment and acknowledge that. I'm pleased today to have Dr. David Armstrong, Douglas Chair of Nutritional Research and Professor of Medicine and Gastroenterology, co-chairing the rounds with me. David will be introducing our speaker in a few moments. But I want to take also a moment to give my great and sincere gratitude and thanks to every one of you who's attending this morning and all the members of the departments who are unable to attend this morning as we're managing these extreme challenging times that none of us have seen in our life before, and the pressure of this phase of the pandemic, which causing a lot of issues on our healthcare system, leading to significant staff shortages. And many of you have stepped up to fill these gaps and help us in continuing to serve our patients in these times that have led to, the need for an unprecedented interventions in both, hospital operation, university operation, IPAC, and human resources. So I just want to say thank you so much for all the work you've been doing throughout the pandemic, and hopefully this will be ending very, very soon. Just want to also take a second to remind everyone that if you have time today at 6 in the evening, there is an MSA Q&A session with our hospital leadership, both the CEO, Rob McIsaac, the COO, Sharon Pearson, and our EVP, Michael Stacy. They'll be all there to answer all questions. I know that we have not had a chance to bring in the department together for a town hall meeting with this crazy wave of the pandemic, but I think the MSA session today will be very, very useful and helpful to answer so many questions as we continue to communicate through emails and memos and stuff like that. So without further ado, I'm going to pass it on to David, and we'll take it from there. David, please go ahead.
Thank you. So firstly, I wanted to thank Khaled for giving me the opportunity to co-chair these rounds and to introduce my friend and colleague, Leah Gramlich, who will be talking today about recognizing and tackling malnutrition. It's one of the, as she will point out and explain very eloquently, it's one of the key challenges I think that we face in hospitals. And there is really nobody in Canada who's better placed to talk about this. Leah Gramlich is a gastroenterologist and physician nutrition specialist, and she's a professor of medicine at the University of Alberta. So we've dragged her out of bed for a 6 o'clock in the morning talk, and our gratitude firstly for that. In addition to her roles in gastroenterology and nutrition, Leah Gramlich is the Provincial Medical Advisor to Nutrition Services for Alberta Health Services. She's a founding member and a current co-chair of the Canadian Malnutrition Task Force, and is actually a past president also and a founder member of the Canadian Nutrition Society. She's published more than 100 articles and received multiple grants for her research, and her key research areas include nutrition support, including enteral and parenteral nutrition, home nutrition support, malnutrition, and enhanced recovery, particularly after surgery. So Dr. Gramlich has an interest also in implementation science and uses this approach to advance nutrition care locally, nationally, and internationally. And she has been a major national driver to the need for addressing malnutrition in hospital and some of the strategies that she will talk about over the next 45 to 50 minutes. So Leah, welcome, and thank you so much for joining us.
David, thank you, and Dr. Khalid, wonderful to be here and welcome all. Some disclosures, and I'm going to start with a case study because it's 6 in the morning in Alberta, and that's always how I get my mind going. So Mrs. B.A. is a 78-year-old woman who I saw about a year ago when I was on service and we were in the second wave of COVID. She came in with a GI bleed and a hemoglobin of 68. She had been on Xarelto for atrial fibrillation and over the past months had had increasing symptoms of angina. She also had suffered a fractured hip, resulting in functional decline and weight loss about 3 years prior to admission. If we think about her nutritional status, Mrs. B.A. was 5'6", and she estimated that she weighed about 160 pounds and that she thought she had lost about 10% of her weight, 10 to 15 pounds. She acknowledged that her ability to eat was limited by just simply poor appetite and not feeling well. And in fact, compared to previously, she wasn't able to mobilize. Mrs. B.A. was identified as being at risk for malnutrition. Let's just have a look at Mrs. B.A. Although she's not thin, you can see that she has temporal wasting. She's got squaring of her shoulders, suggesting loss of bulk of the deltoid mass. And you can see that she's got reduction in fat stores. You can see how loose her skin is right there. In addition, she had pitting edema extending up beyond her knees. So her course in hospital was probably a standard course. She was largely fasted for the first 4 days. We're gastroenterologists. She needed a gastro, colon, and preps for those. And in fact, during this, she developed persistent chest pain and had positive troponins with EKG findings of ischemia. In addition, she had increasing peripheral edema. Between day 4 and day 9, she actually had stabilization of her cardiac issues with no further bleeding, and she was discharged home. She thinks her weight history in hospital was that she lost some weight simply by looking at her clothes. You know, like most patients, she hadn't had her weight recently checked either at her doctor's office or in Emerge or in hospital. And she told the nurses that actually she thought her usual weight was 180 pounds. We actually measured her weight on day 3 and it was 167 pounds. And recall that edema that you saw, we estimated her dry weight as being 145 pounds, so significantly below what she thought was her usual weight of 180 pounds. While she was in hospital, she didn't eat well. She had no appetite, she had edema, she didn't like meat, didn't tolerate dairy, and she was only taking some supplements. So in this lady who are about to discharge, I want you to be thinking about this patient or a patient that you might have like her as we talk about malnutrition over the next few minutes. I want you to be thinking about how should we take care of her in the hospital and after she gets discharged out of our care. So with that, my learning objectives today are to help you understand key evidence on the impact of hospital malnutrition. I want you to be thinking about how we might approach malnutrition in the hospital, as well as at transitions of care into the community. And I want to identify strategies, tools, and resources aimed at detecting, preventing, and treating malnutrition in clinical settings. So let's start with a definition. What is malnutrition? Let's get us on the same page. Malnutrition results when there's imbalance between nutrient intake and nutrient requirements. It can occur if there's inadequate intake, impaired absorption, or increased energy expenditures, such as in the case of severe catabolism with multiple long bone fractures. Sustained imbalance in nutrient intake and requirements leading to functional change within tissues of the body, muscle loss, weakness, immune dysfunction, and impact on capacity for recovery and cognition is characteristic of malnutrition. And malnutrition typically responds to refeeding. Remember that inflammation can influence this response to feeding, and we'll speak to that. Sorry, I'll just do it. So if we look at a definition of disease-related malnutrition, because we know that food insecurity, for instance, might lead to sustained imbalance of intake, but disease adds the flame to contribute to ongoing inflammation. So clearly, starvation-related malnutrition, sustained reduction in oral intake without overlying inflammation is characterized as starvation-related malnutrition. And a classic example of this would be anorexia nervosa. In the setting of chronic inflammation, which might be mild to moderate, such as in the setting of organ failure, pancreatic cancer, rheumatoid arthritis, or sarcopenic obesity, we refer to chronic disease-related malnutrition. Acute disease-related malnutrition is seen with severe acute inflammation, such as is the setting in burns, trauma, closed-head injury, or for instance, the COVID patients that we're seeing going to ICUs with really high C-reactive proteins as a marker of inflammation. Remember that inflammation drives catabolism and alters how nutrients are parceled. So why is malnutrition relevant today? Malnutrition is prevalent in hospitalized patients, and we'll share some of that data with you. Malnutrition keeps bad company, and it's associated with bad outcome, increased length of stay, increased costs, more complications. Malnutrition is impacted by hospitalization. Think about Mrs. BA, who was in hospital for 9 days and really was not able to eat for much of that hospitalization. And in fact, what's happening with our hospitalized patients who are malnourished is they're discharged back to community, and they may or may not recognize that malnutrition is playing a role in them. I'm going to give you a little bit of context. David told you about my passion for malnutrition, but I have a bunch of friends that I do this with. So we came together over 10 years ago in the Canadian Malnutrition Task Force as a group of clinicians, decision makers, and investigators, and we formed a standing committee of the Canadian Nutrition Society. Our vision in the Canadian Malnutrition Task Force is to advance nutrition care through research, education, and interdisciplinary collaboration in Canada. Just a bit of a timeline. We really started in 2010 when we did the Nutrition Care in Canadian Hospital study, and your hospital participated in that. We defined the prevalence of malnutrition and the gaps in hospital care and post-discharge, and we identified that malnutrition is costly during that study of 1,000 Canadian patients in 18 centers. Subsequent to that, bringing people together, we thought, we need a way to approach this which could be standardized. So using a consensus-based process, multidisciplinary individuals came together, and we came up with a care pathway, which was content validated, and we tested it in terms of how we can impact malnutrition in acute care. Under the leadership of Dr. Heather Keller from University of Waterloo, we then undertook the More to Eat study in 5 hospitals where we implemented this care pathway to address malnutrition, to identify it, to prevent it, and to treat it. And then we scaled that out to 10 hospitals between 2018 and 19. We'll share some of that data. More recently, over the past 2 years, we've been working on developing a national malnutrition standard, which actually was recently published by Health Standards Organization in Canada in September of the last year. So we're trying to work globally to empower every patient in every hospital and every community through our structures to advance nutrition care. Let me compel you with some key evidence so that you know how important this is and you'll be keen to address malnutrition. So at a 10,000 foot level, malnutrition has repeatedly been shown to be associated with increased mortality and morbidity. It's associated with reduction in wound healing, increased infections and complications, reductions in convalescence, increased frailty, and all of these factors can lead to reduction in quality of life. In addition, from a health system perspective, it leads to increased treatment costs, increased length of stay. So it impacts not only the patient, but the health system. Our nutrition care in Canadian hospital study was published in multiple venues, and Joanna Lard was the lead author on the study that really described the prevalence of malnutrition. So I'm going to get you to look here. We looked at 1,000 Canadian patients across community and academic hospitals, and we found that indeed 55% were well nourished. However, 1 in 3 were at risk for malnutrition or moderately malnourished, and 1 in 10 were severely malnourished. So if you think about your hospital today, you go see your patients on rounds, almost half of them will be well nourished, but the other half are at risk for malnutrition or severely malnourished. We've also undertaken a study in pediatric patients, and 1 in 3 pediatric patients are malnourished on admission to a tertiary hospital. Canada 2022, who is malnourished? Because sometimes it's hard to detect given the prevalence of obesity, and the average BMI in the Nutrition Care in Canadian Hospitals study was 26, and a third of the patients in that study had a BMI of over 30. We use the subjective global assessment as the gold standard to define malnutrition. It's a lumping tool. Patients are defined as A, well-nourished, B, moderately malnourished, or C, severely malnourished. And it's based on the history and physical of nutrition assessment. So the history is nutrition intake, weight loss, GI symptoms, functional status, and then physical exam focuses on fat and muscle stores. So for instance, in this individual, he's had no weight loss, he's got normal nutrient intake, minimal GI symptoms, and he works as a construction worker and has not missed work. He's got good bulk and tone of lean tissue. And although he's fit and not overweight, there's no evidence of loss of fat. In this individual who's 55, he's got a pancreatic neoplasm. He's had 5% to 10% weight loss, persistent nausea because of this pancreatic mass, resulting in reduction in oral intake. He's a farmer who can no longer go out and do all of his farming. And you can see that he's got reduction in bulk and tone of his deltoids, and he's got loss of fat stores that you can see here in the mid-axillary line and then the triceps area. 1 in 3 people in hospital look like this. 1 in 10 look like this, severely malnourished. This patient's had more than 10% weight loss, severe reduction in oral intake. She can't swallow and she's got features of lower GI bleeding. She's bedbound and requires oxygen. And essentially you can see veins beneath her skin. That means she has no subcutaneous fat. She has no muscle. She's got major loss of fat and muscle. She's severely malnourished. Picaxia is a new term that we're really banding about. Muscle wasting can occur due to chronic inflammatory disease. And in fact, this type of wasting doesn't respond to feeding. So it's a subcategory of malnutrition. This is a woman who has an inborn error of metabolism with mitochondrial dysfunction. So no matter how much we feed her, she can't put that nutrient store into functional capacity within muscle. This is cachexia. So is it all about hospital food? I would say no. When we looked at our 1,000 patients, we actually asked them, what are your troubles? And patient reporting eating difficulties in hospital included poor positioning for eating. They were interrupted by staff. They got food that they didn't want. They were disturbed at meals. They had trouble reaching meals. They were away for tests. When they were away for tests, they didn't get food. And in fact, when they needed help, they didn't get it. This was before COVID, when we had isolation and we had to doff and don before you went into each room. And so the situation with COVID has probably altered. Does malnutrition predict length of stay in our Canadian study? Yes, absolutely. So think about hazard ratios of less than 1 predicting a longer length of stay. And you can see that patients with SGA B and C had a longer length of stay. Those with greater functional status, as it marked by hand grip strength, seem to have a reduced length of stay. Those requiring nutrition support, enteral or parenteral nutrition, those are very sick individuals and they had an increased length of stay. One of the most interesting pieces of data that came out of the study that I found was that patients who eat less than 50% of their intake have a prolonged length of stay compared to others. I often round in the mornings, I lift up the trays and I see what patients are eating. So, impact of malnutrition on hospitalized patients, length of stay is impacted, and developing malnutrition during hospitalization results in a longer length of stay. In our Canadian study published by Laurie Curtis, patients with malnutrition were 3 days longer than those without malnutrition. In studies from Latin America and Australasia, length of stay can be as much as twice as long. Malnourished pediatric patients are more likely to be readmitted to hospital. And in fact, in our Canadian study, they had a 1.6 times likelihood of being readmitted to hospital compared to well-nourished patients. In a study from Singapore, mortality was increased 7-fold at 2 years in the severely malnourished patients. And we saw a mortality difference in our patients, and cost is increased. Malnourished patients cost more than those that are well-nourished. And this added cost is independent of the disease state. In the Canadian study, malnutrition resulted in an increased cost of $1,500 to $2,000 per patient, largely related to the length of stay, and the cost to the health system is not inconsequential. It's important for us to think about how we're looking at malnutrition in hospital. Weight is really important. So weight loss of greater than 5% is associated with increased length of stay. Weight changes after discharge, with 1 in 4 patients reporting reduction in weight loss after discharge. And these weight changes are important for pediatric patients as well. Measures related to food intake are relevant. 1 in 3 adults in our study had difficulty meeting their needs. And in fact, 1/3 of our patients ate less than half of their food in hospital. Pediatric patients meet less than 50% of their needs. Just going to throw in a COVID slide. There's lots of evidence about this, but COVID clearly has an impact on oral intake symptoms, whether it's related to anosmia or anorexia. In addition, we know that at least 1 in 10 of these patients with COVID will develop long-haul COVID, and long-haul COVID is associated with frailty and slow recovery. In patients who don't have COVID, social isolation is an issue. Being able to get out and get food and impact on food and security is relevant. If we think about who gets sick and who gets into trouble in hospital, it's seniors. COVID has had a disproportionate impact on seniors and seniors in care. Seniors are also the group of individuals who are at highest risk for malnutrition. The intersection of COVID with other chronic diseases also is puts a spotlight on mortality and morbidity. So it's those who have metabolic syndrome and multiple medical comorbidities who are often feeling the excess burden of COVID. From a health system perspective, COVID is a disruptor that will impact our healthcare system. You guys are living the dream as we are at the Royal Alec. So COVID is here, it's impacting malnutrition. Malnutrition is relevant. So severely ill and critically ill hospitalized patients are high nutrition risk. They have worse outcomes, and it's impacted the complex relationship between food availability, access, safety, and affordability. I have a lot of references here. They're at the end of my talk, and I'm happy to share them with you after. So you might say, Leah, you've convinced me that malnutrition is prevalent, that it impacts outcome, that COVID has made a difference, but can we really do anything about malnutrition? We're busy taking care of pneumonia and congestive heart failure and inflammatory bowel disease. Does it make a difference if we focus on nutrition care? I think there's a few studies that shine a light on this. Oral nutrition supplements are clearly a strategy that have been proven to improve outcome in a variety of patient populations. Certainly those who have cognitive impairment, those who are elderly and frail. Studies have been done in orthopedic surgery and fractures, general surgery, cancer, with respect to the development of skin breakdown. This is with or without other dietary interventions. So the use of oral nutrition supplements have been shown to make a difference to improve intake. I really like this study. It was my favorite study from 2019. The EFFORT study, published in The Lancet, was undertaken in 5 Swiss hospitals, medical units, so populations that you take care of, not surgery or critical care populations. And over 5 hospitals, they accrued over 2,000 patients who were randomized to specialized nutrition care or tailored protocol-guided interventions to meet protein and calorie goals compared to standard hospital food with no dietary consultation. And these are in patients who screened at risk. With this intervention, you could see that Pink is intervention and blue is control. So with a targeted, tailored intervention to increase protein and energy intake, we can increase energy and we can increase protein intake. So great, tailoring our intervention can help people get more nutrients in hospital. Does that impact outcome? 23% of the patients in the intervention group compared to 27 in the control group experienced an adverse outcome. It looks backwards here because these are proportion of patients with no adverse outcome. So the control group had more adverse outcome. In addition, there's a mortality difference. And so this is in 2,000 patients, 5 hospitals. You can see there's a significant difference in mortality between intervention and control. So what was this? This was tailoring nutrition therapy. The intervention group got about 250 extra calories, 20 extra grams of protein. And in fact, there was no difference in side effects between the nutrition support group and the intervention group. So this wasn't fancy nutrition. In this study, only 1% of the patients got enteral or parenteral nutrition. So this is tweaking their nutrition intake with tailored intervention. Study from 2016, the Nourish Study, looked at common medicine diagnoses, heart failure, acute myocardial infarction, or COPD. And they randomized this group of over 600 patients over 65 years of age. And this was a long-term study up to 6 months. And they got standard of care plus an oral nutrition supplement that was high protein with some fancy bits, or they got standard of care with a placebo. You can see that in the control group, they didn't get supplemental energy and protein. And those who got the supplement got an additional 350 calories, 20 grams of protein, and some micronutrients. And they looked at a combined endpoint of reduction of readmission and mortality. They did not meet their combined endpoint. However, you can see that there's a survival difference between those that got the supplement with heart failure, acute myocardial infarction, or COPD, compared to those who didn't, and that's significant. So another study that looked at over 34,000 patients receiving nutrition support, excluding ICU patients, showed that those who got formal nutrition support, this is using a different methodology compared to those who didn't get nutrition support, had a reduced risk of mortality. So providing nutrition care impacts mortality and impacts complications. Recently, one of the discussions that's come out in the world of malnutrition have shone a light on international efforts to define nutrition care as a basic human right. Nutrition care includes the right to screening, assessment, and evidence-based nutrition therapy for malnutrition. I think this is really important. We don't know other areas of care where access to care are a human right, but nutrition care is a human right. So let's talk about how we might support this human right to nutrition care, particularly in hospital and at transitions of care. So best practices in addressing hospital malnutrition across settings include nutrition screening. This isn't something we as individuals do. This needs to be implemented at the level of the health system, and nutrition screening needs to use a simple screening tool, and we need to provide audit and feedback to identify prevalence and strategies to address nutrition screening. Other things that work in hospital to address malnutrition: food first approaches, including high quality food, paying attention to patient preferences, and the use of oral nutrition supplements, specifically high caloric, high protein density, liquid beverages that are easy to take when you're in hospital, and addressing barriers to getting those supplements to people. Involving dietitians actually can benefit food intake and timely care. In the Nutrition Care in Canadian Hospital study, before we put in our care pathway, we found that dietitians were seeing the well-nourished half the time, so someone with diabetes or a bit of swallowing dysfunction, but they were seeing the malnourished and at risk and severely malnourished less than a third of the time. So we needed to tailor the use of that resource to those most likely benefited so that we can use the dietitian's skill to individualize nutrition support and obviate mortality. So this is the consensus pathway that I described to you that was implemented, that we tested. You can see that it's predicated by nutrition screening at admission, and we use the Canadian nutrition screening tool. This is not a complicated tool. It can be done by a clerk. It can be done by a patient. 2 questions. Have you lost weight in the past 6 months without trying? And have you been eating less than usual for more than a week? If you answer no to either of these questions or both of them, you are not at risk. You screen at not at risk, and you should get standard nutrition care. This means we don't fast you, we give you food that you like, we treat your symptoms like nausea, abdominal pain, constipation, so that you're able to eat. And we monitor food intake because we know that reduction in food intake in hospitals is associated with poor outcome. In patients who answer yes to both of these questions, I've lost weight without trying in the past 6 months, and I'm eating less than normal for more than a week, whether you're obese or lean, if you screen positive, you should undergo a subjective global assessment. One of our goals over the past several years is to teach dietitians to consistently use the subjective global assessment, and we're making progress here. It's realistic for physicians to do a subjective global assessment, but I'm not sure it's on our radar. And I think we need to be thinking about how we can get the systems to give physicians a diagnosis of malnutrition so we can act upon it. In patients who are defined as at risk for malnutrition or SGAB, they get advanced nutrition care. This means I tailor your diet and I give you oral nutrition supplements. I position you for meals. I treat your symptoms. In someone who's severely malnourished, for instance, that 1 in 10 patients who's lost more than 10% of the weight, if their intake is not adequate, we need to be thinking of specialized nutrition care like enteral or parenteral nutrition. In addition, one of the key aspects of this care pathway, ongoing monitoring and thinking about nutrition care post-discharge. We've got to be getting a diagnosis of malnutrition on our discharge summary so that the primary care providers and the patients know that malnutrition is an issue that they need to address to impact their outcome. So let me give you an example. Can we implement this care pathway and does it make a difference? So under Heather Keller's leadership, we got a grant from the Canadian Frailty Network, and we implemented this care pathway in 5 diverse hospitals in 4 provinces, and we developed a toolkit to support it. Did it make a difference? We looked at key features. We looked at nutrition screening at admission, and you can see that between admission and the end of the study, we got up to screening of 80% of patients in these 5 centers. In addition, we were very effective in getting a diagnosis of SGA based on screening. Although it's not the purpose of the study, we can see that the length of stay seems to be less post-study. So using an implementation study to address barriers and enablers to nutrition care and to implement key aspects of the nutrition care pathway, we can do that. So what are our learnings from hospitals? Nutrition care pathways can assist. Standard, it's relevant to think about what is standard nutrition care, and you as physicians are perfectly positioned to think about how your patient is eating when they're in hospital, and to use oral nutrition supplements or diet modification or treating symptoms to help people get their nutrients in. Evidence and consensus-based pathways can help, and these pathways, whether it's coming from the US or globally, all have consistent features. They're predicated by nutrition risk screening using a validated tool. And then assessment is undertaken in those who are at risk, and the care pathways need to recommend nutrition care options. I'm going to shift gears because hopefully today your hospital administrators will get you to discharge patients so you can let in those 25 that are waiting in emerge. But we know that most patients leave hospital in the same state that they entered. If they're malnourished when they came in, they are malnourished when they're going out. So that's 45%. And in fact, 1 in 5 can get worse in hospital. You know, someone who has an esophageal stricture, who's got a dilatation, who can now eat, that person will get better. You treat pneumonia, that person will get better, but some get worse. We recognize that it's really important. So think of how we're moving in the Canadian Malnutrition Task Force, and we're starting to identify that when patients leave hospital, we need to connect them with primary care and community services, and we need to identify for the patient that malnutrition is an issue. Physicians telling patients that they're malnourished are really valued key opinion leaders. They might not listen to the dietitian, but if you as their attending physician says, you have malnutrition and eating more, improving your protein intake will help, they'll listen. So at transitions of care and discharge, we can see that 25% report weight loss within 1 month post-discharge, and it's usually related to they're on a new diet with some restrictions or they have poor appetite. And one of the problems in primary care is that malnutrition is not a priority, and there's no opportunity to access or limited opportunity to access nutrition counseling in community. So screening is rarely done, and dietitians aren't commonly used in community practice. However, if we talk to patients in hospital, they will follow recommendations. So best practices at transitions of care and at discharge. Nutrition care instructions at hospital discharge absolutely need to improve because we've identified malnutrition, working with dietitians, using your clinical acumen, using enriched foods, oral nutrition supplements. Okay, I'm going to back up a bit. What are enriched foods? Because I imagine as docs, you're thinking, what's going on here? Think about protein literature, milk-based products, eggs, cheese, meat, legumes, beans, soy. Eating in company is important. The environment for eating is important. Education and tools can help us address this. Oral nutrition supplements prescribed by dietitians are poorly adhered to, but if the doctor says, you know, you'd be well off to take one of those supplements, that makes a difference. Think about duration of interventions in community. That study I showed you, the Nourish study that followed COPD, acute MI, and congestive heart failure, that was a 12-week intervention. So these are long-term interventions. We need to think about follow-up. If there's no dietitian, the physician needs to have this on their radar. We've developed a care pathway for community, and it's a bit beyond the focus of this round, but we've worked with community providers, dietitians, physicians. So nutrition screening and malnutrition diagnosis in the hospital should trigger the hospital team to document risk, provide education and resources, both with respect to considering the role of the medical home and community services, the presence of a dietitian or absence of a dietitian. So we really need to rely on dietitians in community to help target community resources. If dietitians don't exist, the physician wants to be in tune with monitoring weight and appetite. So the role of the hospital team at discharge, being aware of nutrition risk and documenting it, have a care plan, educate the family and the patient on nutrition plan, need for follow-up, provide resources, and make sure that you talk to the primary care provider in the discharge summary about the presence of malnutrition, risk factors that can be obviated, and a nutrition care plan. So using our hospital-based dietitian resources to support physicians to foster that transition plan, really important and an opportunity. So what strategy, tools, and resources do we use? And these are available. I just put them up here to give you an idea of what we've created. And I can tell you that most hospitals in Canada are using the Canadian Nutrition Screening Tool. And this was validated by Manon Laporte, one of our CMTF members. Simple tool. So you as physicians, if you're walking around and if you don't know if you're doing screening, I know at Hamilton Health Sciences you are doing nutrition risk screening, but think about asking these questions. Are you losing weight without trying? Are you eating less than usual? Those are two triggers. This is the SGA form that helps us identify nutrition risk and make that assessment that gives us a diagnosis of malnutrition or not. And we're using this consistently. Food intake monitoring can be done. This is challenging in hospital. Patients don't get it. It's hard to get and analyze the data and hard to use the data. As a physician, I round and I look at what people are eating and I ask them, I lift up their plates. I'm a gastroenterologist, so I'm scoping and I know I'm fasting people a lot. So I try to be conscientious of that. We've got this online toolkit that we've created. Let me give you some practical tools. So standard approaches in hospitalized patients. We can support patients to eat through meal assistance. So whether that's with a nursing assistant, or less likely at this time, family members because of our restriction on visiting. Reduce distractions. At the Royal Alec where I work, we have 4-bed units that now only have 2 patients in. But distractions can be problematic, whether it's related to other patients or care that's being provided in the hospital. Giving patients enough time to eat the meals and positioning them for meals, not lying them down flat. Giving patients snacks to eat, making sure that the meals are spaced appropriately. In Alberta Health Services, often our evening meal is provided at 4:30 or 5 p.m. And between 5 p.m. and the next morning, there may not be food available. So we need to be cognizant of that. Food quality and variety, the ability to choose food, like selective menus, are helpful. You know, some people like an early breakfast. How can we support that? Meeting ethnic needs through allowing food to be brought in hospitals. So in the Nutrition Care in Canadian Hospital study, 1 in 4 individuals had family members bring in food. Now remember, that was 2014-15 before we had COVID. So that's a consideration. What about liberalizing diets? You know, is the hospital the right time to say you are on a no salt diet, when in cardiac patients, for instance, when in reality they're not eating much? That might be something to think about. Not giving medications at meal times. Using a food first approach, high pro, high cal diets. So there are high pro, high cal diets in all of our facilities. Think about using them so you're getting concentrated energy dense foods, emphasizing those higher protein foods at meals and snacks. So, you know, the special cups of puddings. So puddings are rich in protein. Updating food preferences, including the client selections, are relevant. A word about menu planning in hospital. In acute care facilities like Hamilton Health Sciences, your food service probably has a 7-day menu cycle. And so think about those patients who are in hospital for a prolonged period of time, where the menu, they're getting the same food again and again. In our long-term care facilities, the menu cycles are often 14 days or 28 days. So think about variety. There's absolutely a role for nutrition supplementation, high energy dense products. We often try to use MedPass, which is giving 30 mils to 60 mils of an oral nutrition supplement, 2 cals per cc, 4 times a day with meals. So when patients are taking their pills, they take their MedPass. And if you do that 4 times a day, you get 250 mils or 375 calories. Enteral nutrition can be considered with prolonged poor oral intake, or parenteral nutrition in those with no gut function. Snack options and education plays a key role. A little bit about our hospital standard for malnutrition, with which we worked with Health Standards Organization. This was published in 2021, and it's a health standard to help us address the fact that malnutrition is unrecognized and untreated, to help support this concept of nutrition care as a human right. It was published in 2021, and we're currently working with Accreditation Canada to define required organizational practices related to nutrition. If I had to pick one, it would be thou shalt screen for malnutrition, because then we at least identify, detect those patients at risk for malnutrition, and can use our care pathways to implement best care. So required organizational practices might be adopted because it's a health standard. Standards create strong healthcare structures that public providers and policymakers can rely on to ensure high quality services. Health standards are the foundation on which leading edge accreditation programs and public policy are built. We've created this based on the most up-to-date evidence, working with individuals from both Europe and the US to help us create this. We used a patient-centered approach, and we included patients in our development of this health standard. And these recommendations are based on the latest evidence. So adoption of this health standard will help hospitals improve patient outcomes as they adopt methods to prevent, detect, and treat malnutrition. We've worked over the past 4 or 5 months with individuals, and Mary Lee Stickles-White in your area stands out, to advance malnutrition care. We've identified champions in every province, and we're working with them through the Canadian Malnutrition Program to support leadership within each province. So building on the success of More to Eat implementation and the development of malnutrition, we're working to create mentors that can function at a hospital and site level to adopt best nutrition care practices to improve prevention, detection, and treatment of malnutrition. We're going to start early in 2022 and spread this. And our idea is you tell 2 people and they'll tell 2 people. To address malnutrition is a big job. And as provincial medical advisor in nutrition services in AHS, I see a puzzle and the pieces are increasingly being filled in. And I would like to see, hopefully in my time, a much more fulsome puzzle where we're more completely addressing the issue of malnutrition in hospitalized patients through adoption of standard programming. Let's go back to the case and we'll leave some time for questions. So Mrs. BA, 78, heart failure, big GI bleed. She went home and then between day 7 and day 20 at home, her edema resolved and her chest pain got better. She was using oral nutrition supplements to increase her energy and protein intake, and she modified her diet. On day 21, she saw her family doc. She was 148 pounds. And remember, this lady thought she was 165 before her hip fracture. She was 210. She's down a lot. In fact, as her cardiac symptoms improved, her appetite improved, but she was still fatigued. At day 21, we need an action plan to support the family doc. So what can the family doc do? Check and see if the hospital team sent a nutrition discharge plan, recognize that the patient's screened at risk at discharge, assess for malnutrition, think about dietitian services in community, poor factors for nutrition were addressed. For instance, she had her cardiac symptoms treated, the heart failure. We identified food first approaches, arranging follow-up to address malnutrition so that the family doc is seeing this patient is really important. So deep breath, a lot of information, and it's not complex. Malnutrition is out there. When you go around today, I want you to take a look. 1 in 5 are going to be severely malnourished, 1 in 3 at risk for malnutrition, 1 in 2 well-nourished. Those who are older have a greater burden, and recognize that those with poor nutrition status are associated with increased complications and lower survival. There are standard approaches, screening and assessment that can be integrated consistently. Our role in educating families warrants work. Food intake is important to the recovery of patients, and we need to support this through a variety of strategies, and we need to follow up. That malnutrition warrants as much follow-up as does the heart failure or the GI bleed, and we might require additional interventions. An effort should be aimed at linking patients with community resources and services. Food insecurity and functional status issues are of a concern with the pandemic. And with that, I'd be happy to take questions. And I have a list of references associated with this after that I'm happy to share. Thank you.
Dr. Crumlich, thank you very much for a very insightful and practical grand rounds. And I want to affirm you're right. At Hamilton Health Sciences, we are screening our patients. We are using MedPass as a supplement. We probably need to do a lot of work to improve the messaging and the planning on discharge and the plan for the post-discharge care. For those who want to put in questions you either put in the Q&A section, or you can, if you want to come up and speak your question in person, you can raise your hand and I'll bring you in. I'll pass it on to David to moderate the questions.
Okay, thanks very much. That was an outstanding presentation, Leah. And there's a very long shopping list in there. And so I'll come back maybe to some of the implementation issues, but there are a number of questions that we have, which you can probably see as well. I'm just trying to think. So actually what I'm going to do is I'll read out. The first one is from Greg Kernew, who says different experts have suggested different protein intake, ranging from 1 gram to 1.8 grams per kilogram. Does the quality of protein make a difference? Casein, whey protein, for instance. Does chocolate milk provide any value? Does data on nutrition prevent falls? So he's got a number of questions. And happy to go through those, repeat those as needed.
Sure. Thanks, Greg, for those really good questions. So, the World Health Organization says we need 0.6 to 0.8 grams protein per kilo. The average intake is probably around a gram per kilo. 1.8 grams per kilo is high. And in fact, in critical care units, they're pushing that 1.8 to 2 grams per kilo. They're going to study it. It's hard to actually demonstrate benefit of protein above 1.5 grams per kilo. So although that might be what is prescribed, we always need to be thinking about what that patient is taking in. So think about our ICU work, the work of Darren Highland, where we monitor intake, and patients are supposed to get, let's say, 1.8 grams protein per kilo. They're only actually getting in 60 to 70% of that. So they might be getting in a gram per kilo. So what's prescribed as opposed to what goes in, different consideration. And so I typically prescribe 1 to 1.5 grams protein per kilo. So in a 60 kilo person, they should be getting 60 to 90 grams protein per day. Does the quality of the protein make a difference? It's a really good question. I actually have to be honest, I don't know the answer, but my gut reaction is no, it doesn't make a difference. Protein from animal sources versus plant sources has a similar capacity. And I think that we need to be creative in thinking about where protein can come from. One of your other questions I could see, what about beans? People don't like it. So let's think about the individual and tailoring the intervention. So that senior might like chocolate milk. That might have been a special treat from when they were a kid. And if you're trying to get a senior to get nutrient intake, chocolate milk, it's a little bit more calorically dense. You can get 1% or 2%. It's got 6 to 8 grams of protein in a cup of chocolate milk and probably 250 to 300 calories. So in that way, it's similar to an oral nutrition supplement, might not have the micronutrients. If you can get any calories and protein in, I think it's a good way to get calories and protein in. In terms of data on nutrition to prevent falls, we recently did a systematic review with the Canadian Frailty Network, and I don't think there's any evidence that suggests that nutrition can prevent falls. However, it can result in stabilization of weight and potentially function, which might relate to a reduction or increased prevention of falls. So I don't know if that answers your questions.
I think from my point of view, speaking on behalf of Greg, I think that's that covers pretty well all of the bases. And I think, your point of, in a way, it's not letting perfection get in the way of the perfectly good.
You got it.
If you get some food on board, then that's better than nothing.
Well, and think about what the patient wants. One of my best questions is, what time of day is your best time to eat? Because there are some people who are morning eaters and there are some people in the morning who can't eat. And so I often ask that person who's malnourished, I rather than say, you got to eat breakfast, lunch, supper, you got to eat more protein, I'll say, what's your best time of day to eat? Let's work by making that more fulsome and trying to slip things in. I listen to meal skipping. I listen to, so my diet history, David, I say, what'd you have for breakfast? What'd you have for lunch? What'd you have for dinner? Do you have any snacks? And what are your beverages in hospitalized patients? Think about water as a volume, but having no caloric density. And oftentimes seniors might drink tea or water, particularly at meal times, and that can result in early satiety, limiting intake of nutrient-rich stuff like solid food or nutrient-rich liquids. So thinking about what beverage people are drinking is relevant. So in people who drink water, or that's their only beverage, we need to be considering that. I saw there was a question about obesity and food choice. Many of my patients are obese. They may be sarcopenic. How do I approach this? Illness is not the right time to be focusing on weight loss. And so in the sarcopenic obese individual, we think about the Mrs. BA who I presented. She weighed 210 pounds 2 years ago, BMI 35. Then it was down to 31, then down to 28. She thinks she's heavy and she's thinking, great, I'm losing weight. I've always wanted to have a BMI or, be under 180 pounds. And it's a common misnomer. People with cancer will say, oh, gee, maybe I'll lose that weight that I've got. But illness is not the right time to be losing weight. And you really need to be focusing on protein nutriture in the obese individual. So that's an individual who you might want to shoot for 1.5 grams protein per kilo of a body weight based on a BMI of 25. Think about the dosing weight for energy. So focusing on protein nutriture and micronutrient nutriture, adding a multivitamin every day, and ensuring that you meet a minimum of energy requirements is a good focus. There is a question about, affordable protein. Beans may not be that palatable or the preferred choice for an individual. Milk products are a really good source of protein. Skim milk powder, any of the milk products are really something that I back into. So I like to cook. So I'm always thinking, okay, when I'm talking to patients, I take that dietary history and I think about what they're eating. And I think about high fat yogurt products like Greek yogurt, 16 grams of protein in a cup, that is high protein. So can you mix it in with things? So because I like to talk about food, I often listen to patients and hear how they eat. And in that way can turn food into medicine. I tell them that you are malnourished, so I raise awareness.
Thank you. So there's a question here. I wonder if Anna Holbrook wants to elaborate. She has a question regarding the role of feeding tubes.
Thank you. Yep, here I am. Sorry.
Hi, Anne.
Hi, Leah. So I think everything that you've said actually is fairly well practiced in Hamilton. Dave would probably beg to differ on a routine basis, but at least those of us that cover general medicine, I think, are pretty aware of the importance of diet. Where we really struggle, our nutritionists, by the way, I would say are pretty on top of this as well.
Yeah, I'd agree 100%. You guys are rocking it.
Where we really struggle, and I have a significant sort of issue as well, is the feeding tube. So we have certain nutritionists who are actually chronically pushing us to insert feeding tubes. I would say, I've done this for over 40 years, I would say at least 30% of our population is towards the end of their life with fairly advanced dementia, those that are malnourished I'm talking about. And I do not see a lot of hope of turnaround in important functional outcomes. So, and I have not seen a lot of good evidence around enteral feeding tubes themselves turning around important clinical outcomes. So my question is, who should we really be focusing on in the internal medicine population that's really going to benefit from a hospital-only enteral feeding tube? And do we have any randomized trials to support that?
You raise a really good point because, you get standard nutrition care for everyone, advanced nutrition care for those who have poor oral intake, and specialized nutrition care is enteral and parenteral nutrition. And there's no clear-cut indication. So if we think about the burden associated with prolonged reduction in oral intake and intake of less than 50%, resulting in worse outcome, that's probably something we should be triggered by, Anne. The patient population you described is patients with advanced dementia, and that's a unique consideration because thinking about non-volitional feeding in the patient with advanced dementia really begs the question about goals of care and outcome related to non-volitional feeding. We know that 6-month survival in patients with advanced dementia who get PEG tubes, for instance, is only 50%. You've been an internist for 40 years, and I'd suggest that you've got a lot of clinical wisdom and you're navigating that pathway with families. These patients with cognitive impairment who come in maybe with a pneumonia, that might be the pivot point where they make that turn. So who can benefit? So I think that's a really important question. If function's impaired and they're malnourished and they've got a reasonable long-term prognosis, I think we need to be using specialized nutrition support, so tube feeding. In the medicine population, so that SHUT study, the prevalence of tube feeding was only 1%, Anne, and this was on a medicine unit. In ICUs, they use a lot of tube feeding. In surgery, they don't use much tube feeding. In surgery, they use TPN. One of the adjuncts we're looking at is the use of peripheral parenteral nutrition. All of these patients have IVs going. If you run peripheral parenteral nutrition using a standard bag, a premix solution, you can get 1,500 calories, 60 grams of protein a day if you run that at 80 cc's an hour and you meet their micronutrient requirements. It's low in potassium and phosphorus, so you need to replete that. So Anne, I'm actually patients don't want tubes, nasoenteric tubes. There was a study from the Mayo Clinic. Do you want an NG tube or do you want parenteral nutrition? Patients say, forget the NG tube. I want parenteral nutrition. You know, don't put something down my nose. So there's that paradigm that we're struggling with. I don't think it's a well-answered question. And I think if your spidey senses are telling you this patient has advanced dementia and feeding is not going to prolong meaningful life, then you're right to question that. I don't know if I've answered your question.
That's a great point, and I think there may be more discussion or maybe another round on on nutrition of the elderly, especially in those who are in end of life. We're at time. There's other really good questions. Unfortunately, we will not have time to answer them. So this has been really a fantastic rounds and great discussion. So I want to really thank you, Dr. Bramlich, for joining us early morning at Alberta, and thank you very much, David, for co-chairing. And I wish everyone a fantastic day.
Have a great day. Nice to see you all. Thanks, David.
Thanks very much, David. Great to see you.
Yeah.
Thanks very much, Khaled, and wonderful day to everybody.
Thank you.